Dr. Fontaine, I just have a question for you. Most chemotherapy is given every 3 weeks, and you're giving yours every 4 weeks. Is there a reason for that?
Well, I think it's just because it had been proven in Dr. Vogel's study to be safe and had some response rate. They want us to base ourselves off in our study. Yes.
Any other questions? Yes?
Well, I've been coming for years because my husband passed away due to this disease. But my question basically is, I have learned an awful lot about this disease. But when we were diagnosed, we were told by one doctor, I don't want to see you, I've never seen this disease. That was one doctor's response, very honest, I thought. But then again, by the time we found someone that knew something, meaning he'd previously treated mesothelioma, hadn't just read the rule book, you know, you get desperate. You know, the ticking time bomb is dropping down. So you don't have time to learn all this stuff. So how do you know? You keep saying, well, you know, look and try. You don't get these options. So that's the thing. The patients are desperate. And the thing is, how do we find out enough information to be able to make any kind of a good judgment? Is it better just to wing it and just, you know, keep your fingers crossed and pray? Or is it better to try these and hope for that extra 2 years, 3 years that turns out to be 25 days instead? You know, how do you know that we're not kind of leaping at straws by the time we get to talk to you guys?
Well, I think it's important, well, nowadays with the age of the internet and Googling, and it's very easy to be able to find mesothelioma centers, whether it's here or in Europe or in Canada. It's important to go to a center where you have under one roof multiple specialists, all specialized in mesothelioma, from different disciplines working together. So the medical oncologist and the radiation oncologist, and places that have an interest in it and have trials, whatever the trial is. So I think if you go to a center that has an interest in it, that sees a lot of patients, then you'll be offered a lot more options. And I think that's the best way of going about it.
I think also, unfortunately, you know, we as physicians don't know what treatments work and what they don't. You know, there's almost no randomized trials outside of the chemotherapy trials and the Mars-1 trial, which failed in its feasibility. So it's been difficult to get a lot of randomized trials for a variety of reasons. Part of them is physician bias, which really taints our ability to kind of work together, I think. And that, unfortunately, doesn't help you because you can read totally different things. And I've been part of symposiums where I will talk and then the person after me talks and says the exact opposite of what I said. So, you know, all you can say is that we don't actually know. I think that the comment that Dr. Fontaine and what Dr. Olevsky have been showing is that there are a lot of things that can be combined. The problem is we have not a clue as to how to combine them. I think that there's good tools out there to figure out what's going to work, but we have to do it in an organized way with more collaboration between centers so we can do good clinical trials. The French have got a good system where they have, I can't remember how many centers they have in their mesothelioma system, and they can do clinical trials pretty rapidly, which I think is a really good thing. Although I reviewed a paper recently, and they had, I think, per year, maybe 4 surgeries done, period, in France for mesothelioma, which I think also is being neglected. So. But at least if you can do clinical trials, you can answer questions. But you know, a lot of the new therapies, chemoperfusion, I mean, that's, I think, is really potentially useful in certain situations in particular that I can think of. But we have to do the randomized trials to really see if it works.
But how, like when I was looking for somebody, our case manager, she never sent me to UCLA or to USC. She kept sending me to doctors that basically this was their first case too. So when you don't have, when you're dealing with not only being sick but insurance, you have the problem of being sent somewhere, well, that's not knowing. You know, that's the problem, is how do we get over that hurdle? Because all case managers have heard mesothelioma is a losing case. We don't want our insurance company to pay the bills. And that's basically the way they look at you. They know you're a dead man walking. I'm sorry if anyone here is sick. but anyways, that's how insurance companies look at you. So therefore, they don't want to really send you to somewhere because they figure they're going to pay for this, and then 6 months later, you're going to be dead anyways. So we're really fighting a really losing battle. We don't know how to be sick, and we don't know how to get treatment.
I think that's partly a U.S. problem. You know, in Canada and the U.K. and other places where they have centers and they don't necessarily fight over reimbursements, you can have referrals to centers a lot easier. I've had people right down the street from me that didn't know I was there. And, you know, the internet helps with that, but unfortunately there are referral patterns that doctors typically use in the local environment, and they use that all the time, and they tend to use it for even rare diseases, and unfortunately they don't always help you as much as they really should. And I think that's primarily a U.S. problem as well. So.
Well, it's also a dual problem in the sense that it's a very rare disease. And if we can compare it to any other disease, breast cancer, colon cancer, there are hundreds, thousands more patients where trials can be done much easier. So I think that the way to really fight this is education, is to meetings and symposiums, and to really try to seek out doctors that are familiar with it. And I'm just echoing what both speakers are saying.
Yeah, one of the functions of this meeting is trying to get local oncologists and other professionals who see, pulmonologists who see patients with mesothelioma, to kind of understand what's out there and what they can do for their patients. But it's been really difficult, even though I sent personal letters to everybody in the region inviting them to come here. It's just hard to get medical oncologists and pulmonologists and people interested in learning about a really, really rare disease that they, you know, almost never see. So it's a problem that doesn't have a really easy answer, unfortunately.
I have a question. It has to do a little bit, Dr. Cameron, what you said about the pharmaceutical company and interferon and not wanting to use its single dose, but it has a new extended dose. And I was just wondering if the problem with that is that the patent for the interferon runs out in 2018, and then even more recently, the ability to get another patent on a different type of modification of interferon was denied for utility. But perhaps education there too could be a situation where you might be able to impress upon, with the right advocacy, the patent office and with the pharmaceutical firms, that they can perhaps do something with they could modify their patent perhaps with some of these other combination opportunities to get a new patent, which would allow them to have a trial.
You know, yeah, I don't entirely understand the pharmaceutical industry entirely, but you know, I approached them and they seemed actually interested initially about an interferon trial, but it was right when they released their weekly dosing of the interferon alpha, and I said, well, all the data we've done has been in daily doses, and I'm not sure if the weekly dose is the equivalent. They said, oh, well, that's fine, you can do it. And so I said, well, how about if we do a randomized phase 2 trial, phase 1-2 trial, and do both, do one versus the other, and you'll win because you have both of them. But they didn't want to do that because I don't think they wanted to show that their new dosing wasn't very good or wasn't as good as the previous one, so they were trying to sell their new dosing. So I think that was what was going on, but it just kind of was disappointing because we got initial interest and then they kind of said, no, we're not interested. And it's hard to run clinical trials like that unless you have some kind of support from someplace.
I have two questions for Dr. Fontaine. In your screening, you mentioned you did a CT scan, but you didn't mention a PET scan. Was there any reason for that?
Well, if I didn't mention a PET scan, that was an oversight. No, we do perform PET scans, yes.
Well, because there is a problem with that. In my case, I'm covered by Medicare and supplemental. It is extremely difficult to justify a PET scan. I mean, they'll do a CT scan, which doesn't show it, or chest X-ray, MRI, that doesn't show it. It's only in the PET scan that will do it. But normally, it's very hard to justify getting it. That's why I was asking that question.
Well, in mesothelioma, we have not, to my knowledge, we have not had much difficulty in getting a PET scan approved. Now, sometimes some insurance companies require a physician to call to get approval, so it's called a peer-to-peer, and you have to call the physician that works for the insurance company. And actually, to be honest. In 12 years, every time I've called an insurance company to get something approved, where I've actually taken the time and on hold and talked to somebody, as soon as I talk to that physician with the insurance company, I've never had anything denied. But it takes time for the provider, for your doctor to go through that hurdle. But once you do, usually it gets approved. I'm not sure if you have the same.
Yeah, in California, it's sometimes a little more difficult. There's a few more HMO patients, and we've had problems where they won't approve a PET scan for literally 3 to 5 months. And again, it's kind of a delay thing. I don't know why. They eventually do, but it takes them 3 to 5 months to approve it. And we're sitting here trying to figure out what to do with the patient before you get one. Dr. Nowak, I think you've looked into PET scanning for prognostication and everything. I don't know if you have any comments about that problem, and probably it's not existed in Australia, maybe. This is Dr. Nowak, who's going to talk in just a short time, so we'll introduce her.
Let me just clear this out, and you can go ahead. The second thing is pleural mesothelioma considered a blood cancer or a solid cancer?
A solid cancer.
Solid cancer. But you had your slide up there with a showing cutting off the feeding to the cancer tumor itself through blood.
So it's a way to deliver. So you want to get the chemotherapy to the cancer cells. So you can either apply it topically, like you pat it on the cancer cell, or you can give it through the vein and then it goes through the blood supply to that cancer cells, or you can try to find the blood supply specifically for those cancer cells and then give it more specifically to the blood supply to that cancer cell. So that's the whole point of our study, is to try to give more chemotherapy to the cancer cells by selectively giving it to the blood supply of that cancer cell. So therefore you give more chemotherapy to the cancer and less to the good body parts, so less to the liver and the kidneys, by giving it in the blood supply to that cancer cell.
Okay.
So therefore we can minimize side effects to other organs and increase, hopefully eventually will increase the dose of the chemotherapy.
Okay. The reason I asked the question is in getting into the immunotherapy area, I'm seeing references, and I don't quite understand it. It's a complicated area. Is using CAR T on the blood cancers and using TCR on the solid cancers. Am I missing something there?
No, I think you're getting into an area that's still way highly experimental.
Oh yeah.
Except in certain hematologic cancers, CAR T cells is just an experimental treatment. It has been approved by the FDA for blood-borne, leukemias, but it's not available for solid tumors, and so I think that's kind of off on a tangent. But that's something that I think we may talk a little bit more about this afternoon. Some people may mention that, but we had a speaker here last year talk specifically about CAR T cells, which is something people are working on, but it's just not ready for prime time yet.
And most of the advances that have been made in CAR T cells are in hematologic cancers. So that was the first area where they were studied at. But again, some of the other cancers are more immunogenic, and they are being moved over to the solid cancers as well.
So,
my last comment for Dr. Cameron is your diagnosis was correct, but I'm pleased to report that your prognosis was a little premature.
okay. Dr. Nowak, did you have a comment about the PET scanning issue?
I think PET scanning is a modality that is appropriate to use selectively in mesothelioma. In Australia, we don't have a problem obtaining PET scans because we have a federally funded system that is not reliant on the whim of an individual insurance company, which is a great system to work in. Obviously, planning for surgery, PET scanning can be important in ensuring that there are no metastases or nodal involvement that are going to preclude surgery. The other use that we find particularly important for PET scanning is identifying measurable disease or disease that's underneath a pleural effusion that we can't see very well on CT scan, or identifying a really good site for biopsy as well. But in a lot of patients with more widespread disease who are going to have systemic therapy alone, CT scan is adequate. PET scan may support information on response or information on prognosis, but it may not be absolutely necessary.
I have one other question for Dr. Fontaine. I was curious about your selection of methotrexate versus pemetrexed for the trial. What was the thought behind that? Why couldn't you just use pemetrexed?
To be honest with you, there was a medical oncology panel that ended up choosing, because none of these patients can go into the trial unless a medical oncologist signs off.
Sure.
And then goes to the interventional radiologist. So I'm not sure if maybe you have, as a surgeon, I did not have much choice in terms of what chemotherapy we chose, but I'm not sure if you made.
Well, is there some reason you think that you can't do chemoperfusion with pemetrexed?
I don't know about chemoperfusion, but multiple agents, as I'm sure the medical oncologists know and people in the audience, have been tried in mesothelioma as single agents and actually systemically have not been effective. And that's why there was so much lag time and so long until the combination chemotherapy was worked out. So hard to know if that was in Europe or in Canada. The original trials were done with the methotrexate, but Dr. Nowak?
Yeah.
The Dr. Nowak mentioned that it's possible because the patients came from medical oncologists and all of them had chemo, that they're pemetrexed resistant.
I think my question will be for Dr. Fontaine. As a basic scientist, we often don't think about delivery methods of drugs. We are understanding the molecular mechanisms of the tumors. So do you know if whether you're doing, I guess it was a catheter delivery or whether you're doing the arterial delivery, if you're actually increasing the concentration of the compound locally to the tumor? Is there any evidence that one is better than the other?
That what's better than the other?
That you're actually getting a more local accumulation. So instead of just systemic delivery, we can. So, you mentioned I think a catheter to the
so
cavity, or the arterial delivery has been measured.
So it's an arterial catheter. It's cannulization of the femoral artery. So it's a catheter where we selectively cannulate the internal mammary or the intercostal arteries. So it's a theoretical advantage that there would be a higher, or we presume there's going to be a higher concentration of chemotherapy in the tumor cells if we deliver it that way as compared to systemically, but we don't know that because we don't have any receptors, we don't have any monitors, and it's not done intraoperatively. It could be. I'm sorry. Go ahead.
Just there's really no evidence that it is actually an increased concentration locally through that delivery method.
No, not in our study. We can't tell that. We can't confirm that.
I guess I understand that you're presuming that it would. I was just wondering if it actually was shown by anyone that was the case.
Did they in Germany biopsy the tumors after doing the perfusion and see what the level was, or no?
No, unfortunately they did not. No. Now there may be animal models to show that. I presume there are, but it
might be kind of hard to do.
Yeah. But in the German study that was published in ours, we're not monitoring. There's no biopsy done before and after the perfusion.
Right. Dr. Nowak.
Actually, that was along the lines of my questions to whether there were animal models, and I would imagine you could use large animal models such as sheep or dogs. Sorry, I know that's distasteful to many people, but it can be useful. Any thought of doing that?
I think that would be, and it would certainly be very important or interesting to do that, but we have not done it yet. We don't have the funding to do it yet. So we are just starting off with this trial and then see if we can see a partial response, yes. But that would be the best way to do it, is with large animal, I agree.
Let's say you saw the responses that you've seen in a few, I guess.
Yes.
And so you,
In about 40%.
there's a low, so you get a low percentage, but and it's not dramatic, but you do see responses. How would you plan to proceed after that in terms of what would the next study be? Would you try randomizing patients to further systemic chemotherapy versus chemoperfusion? How would you build on what you're doing?
I think that once that would be, well, if we see a response and then they end up progressing, I think if we're able to deliver it systemically, safely, without complications, then the next thing would be to deliver other types of therapies locally. And certainly I think the next one would be immunotherapy for those patients. Well, first would be the dose escalation and then immunotherapy. And one of the problems we have with recruiting patients to our study is the fact that we have 3 studies right now for mesothelioma in our center, and the patients all have to come through medical oncology to get to that chemoperfusion study, the arterial infusion study. And then so the medical oncologist who's the PI on an immunotherapy study is more likely to enroll the patient on an immunotherapy study. So then it's harder to get the patients in the interventional radiology study.
Yeah. Okay, Dr. Nowak.
Sorry, another
It's okay,
question.
no problem. It's good.
Just wondering if you've considered treatments such as spheres, which are used for intra-arterial delivery of radiotherapy for hepatic metastases. That's something that could potentially be considered in mesothelioma?
Yeah, chemoembolization versus chemoperfusion.
Selective,
Yeah,
yes.
yeah.
I think that certainly has a future. We've been doing it for liver at our center, so I think that certainly could be another option down the road. We just have to make sure that we're able to do this first one and do it safely, and then show that the delivery method can be done reliably and safely, and then start different types of therapy that we deliver that way. So certainly spheres would be the next step.
I have a question for Dr. Fontaine. So do you have isolated lesions, that patients that you select, they recur locally? Or there is more than, do you limit it to?
Yes, well,
local
certainly,
numbers?
so mesothelioma that's found all over the pleural cavity, it's very hard. They're going to have multiple arteries feeding it. So we can't, the interventional radiologist cannot cannulate every single intercostal artery or branch off the IMA. So what they do is they target either the symptomatic lesion or they target the main lesion, and then they do it that way. And then the next 4 weeks later, if they see that there's a response and the patient has no more chest pain in that area, then they'll go to the next one. So certainly this is not in a way for curative intent. We can't go and selectively perfuse every single lesion. So we have a few target lesions like the ones I showed you. So yes, that's a very good point. They concentrate on a few lesions, the symptomatic lesions if possible.
I'm not sure if I saw this, but how many arteries do they typically cannulate on, like a mean number of arteries they cannulate per session?
They usually try to do 2 to 3 arteries, depending on how well the patient's tolerating it. And then sometimes when they just can't and the patient just can't tolerate, especially by the 4th, 5th. I mean, we have some patients who are now at their 7th treatment. Then they sometimes, at the end, they just do 1 intercostal, and then the rest they do in the thoracic aorta.
And so if they have a plan like 3 or 4 they're going to try and do when they look in there, and then they divide the dose between 3 and 4. How's the dose get divided, and how much they give into each artery?
It's well, they start off with, they never go more than 3 arteries, just because of the time constraint of the dye, the radio. And then, so they divide by 1/3. And if they just can't do the 3rd artery, then they'll just give a bit more to the second one.
Okay, so do they make a distinction on, like, hey, there's a big feeding artery, one big feeding artery, and a couple other small ones? Do they put more
So-
chemotherapy through the big artery, or do they just do equally still?
So to be honest, it all depends on the initial aortogram, and then they see if they're lucky enough that there's only one target lesion and there's one beautiful intercostal that goes to that target lesion. And they'll say, well, and that's the only place where the patient has pain, they'll give 100% right away. So it's not part of the protocol. We leave it up to the judgment of our interventional radiologist, but they try to do, but they never do more than 3 lesions. But again, it's a targeted lesion, the most symptomatic one.
Okay, thanks. Any other questions?
Yeah, I just want to mention one thing because definitely we are learning while we are doing more study and research. One thing I want to mention is that we learned also more recently that people with germline mutations, their disease looks different. So they have much better survival compared to those random sporadic mesothelioma patients. And based on our previous study, we published that already, people with germline BAP1 mutation can have 7 times longer survival compared to other meso patients. So therefore, later on, I think that need to be taken into consideration when we design some clinical trials. We need to randomize those patients, at least check their background of germline mutation, because if you put a few BAP1 patients in one arm, that will influence the results significantly, despite what kind of treatment you gave him.
Yeah, exactly. This is Dr. Henning Yang, by the way. She's going to give a talk a little later, too. One of the things I just want to say regarding that, and Jacques' comment about selecting patients. Selecting patients is a two-edged sword. I can take a bunch of patients with epithelial mesothelioma, early stage 1 disease, no lymph node involvement, and I can give them a chocolate bar, and they'll do really well. So just because you can select a good group of patients and do something to them doesn't mean you're actually accomplishing anything. So you still have to go back and do a trial to show that what you're doing actually is making a difference, because you will find people that will do well on their own. And it's like when I first was a surgical oncologist, I got really frustrated because most clinical trials that were getting reported were looking at chemotherapy, and they'd say, well, responders did better than non-responders. Well, it's like, duh, they always do. So you have to look at a good comparison and not just say, well, look, we found the best survivors, we did surgery on them, and so therefore surgery is indicated. I don't think that's even true.
Yes, I'm Doug Campbell. I'm the International Vice President for the Heat and Frost Insulators. Many of the members I represent have been exposed to asbestos, including myself. A couple of 3-part questions, getting back to the ladies' earlier discussion. And I don't know if this is going to be coming up later, but I believe there was a pending test on what they call a blood test for a meso marker sort of a thing. I don't know where that's at or if that's going to be coming a little bit later in the discussion. Also, obviously, early detection is one of the keys to this because as Dr. Fontaine had mentioned, many of the patients he sees, they're already in stage 3 by the time you see them. And what I find, obviously, is we'll get patients that by the time they find out, it's really almost too late. You start scrambling around. You're looking on the internet. You don't know what's real. You don't know what's fake, all that kind of stuff. And then just the third part, we've participated in low-dose CT scans as an early detection technique in an attempt to try to get a lot of our members that early detection stuff. So anyway, I just wanted to bring that up, and again, I don't know if this meso marker will be coming up, and I think the indication was that it could possibly show a predisposition for someone that may have a tendency to be more susceptible to meso than someone else.
Well, I think there's a couple of things. The mesomark test has not been very successful, at least in my experience. We did 30 patients pre and post-op, and the pre-op levels were basically normal in almost everybody except for 2. So it wasn't useful in determining disease status for sure. We were hoping that it would be able to kind of use for follow-up to see recurrence and that kind of thing. However, you're sitting really close to Dr. Yang, who last year gave a really nice talk about HMGB1 and how that can actually be used to monitor patients for asbestos exposure and the inflammation that causes, and the 2 isoforms that can be associated, one with mesothelioma actually occurring and one with the inflammation that kind of potentially could lead to mesothelioma. So we can talk about that a little bit more offline, because that was one of the things I did want to talk to you about, because we could potentially look at that in the members of your group that know they have asbestos exposure. I heard the third part of the question. What was the third part of the question?
The low-dose CT scans.
Oh, yeah.
and early detection.
I personally, I use it on anybody who's been exposed to asbestos because asbestos is a risk factor for lung cancer. And if you want to look at something that really raises the risk for lung cancer, is if you have a smoker that has asbestos exposure, it goes up about 38 times. So I think that can fit in the group of patients that would benefit from lung cancer early detection, let alone the benefit of also maybe detecting something a little earlier in terms of mesothelioma, although that certainly hasn't been shown.
But I think in your group in your group, it'd be very important to recommend CT scan screening, not necessarily for mesothelioma, but for lung cancer, because they're much more likely to die of lung cancer, especially the smokers, plus asbestos exposure, are much more likely to die of a much more common lung cancer than mesothelioma. And we do know that lung cancer screening is useful. So I think CT scan screening is useful, but not for meso. You may catch meso, but it's mostly for lung cancer.
Okay. This is for Dr. Cameron. In talking about the BAP1 gene and BAP1 protein, there was in my own biopsy results, there was no mention of the status of BAP1 or the PD-L1 expression. And this was a little disconcerting to me now, later, because one of the reasons I couldn't be accepted in a drug trial out at City of Hope Hospital was that they had no record of me of what the PD-L1 expression was, whether it was high, low, or whatever, and that was a requirement. And they went back to UCLA and found out there was nothing left of the biopsy. I'd signed a release to share it, which turns out to be a mistake on my part, I guess, because it just was gone. And I'm not really qualified insurance-wise to go back for another biopsy in that particular area. Is there, I would think that would be one of the things that would come out on a pathology report is a PD-1 expression.
Well, yeah, have to realize that immunotherapy is not a proven therapy for mesothelioma at this point. So doing PD-L1 determinations, even the data that we have may not actually matter in actually that whole area, but we are doing that now routinely, but the bottom line is it's not something that's been accepted. It's something you normally do. And BAP1, we've done in terms of a clinical trial, but that's not something that normally is done anywhere, typically, except for maybe University of Hawaii, where they have BAP1 germline mutations that they're interested in, but it's not necessarily the standard pathologic workup. Now, having said that, very few pathology departments give away all their specimen, so I would have to look in to see why there isn't any specimen left, and the only potential problem with that is that, of course, lawyers in the U.S. come and they ask for specimens, and they get permission to get pathology specimens, and they often will come in and take a big part of the pathology specimens that we have. But there shouldn't be any reason why you can't get one or two slides from a leftover pathology specimen to do BAP1 or PD-L1 testing.
Okay. The BAP1 is interesting from the standpoint a mutant BAP1. I have squamous skin cancer as well from years ago. And apparently there's some kind of correlation between the BAP1 being mutant for the squamous cancer and succeeding cancers. There's no specific link, but if you have a mutant BAP1, that's a heads up to look for other cancers later in your life.
We're going to hear about that later, so why don't we hold that? We're going to hear about that later.
Okay, so. And the one other comment I make about that is corporate America is using BAP1. If you have a mutant BAP1, they're claiming that it's not due to asbestos, and I don't know if...
again, I don't know anything about that kind of issue, but all I can say about the City of Hope thing is that we were on the same trial, tazemetostat, with City of Hope, and we would do the testing. So if they were in the trial, they should have been able to do their own BAP1 testing. But anyway, so I think it's kind of run the course of our questions. Thank you, everybody, for coming. We have like a 15-minute break here and get some coffee and whatnot out front, and thanks a lot.
Thank you.